Okay, good evening, everyone. And it's my pleasure to welcome all of you today to the CIDS webinar, the first of this year. Wishing everyone a happy Pongal amidst this Omicron pandemic that's going on. We have an academic feast prepared for you. And on behalf of the Executive Committee, Dr. V. Ram Subramanian, who's our president, Dr. Sunita Nareddy, who's our treasurer, and the Governing Council, it's my pleasure to welcome you to this meeting. We will wait just a few minutes for a few more people to join. So in a couple of minutes, we will get online. So do bear with us for 2 minutes. Okay, so I was waiting till 100 people at least got online. It's my pleasure to welcome the first speaker of the day, Dr. Ravi Vasanthapura. Dr. Ravi Vasanthapura is fondly known as Virus Ravi to most of us who know him. His passion for neurology and neurovirology is known to all of us. He's a former professor and head of neurovirology at NIMHANS. He's also the nodal officer for the genomic confirmation of SARS-CoV-2 at the moment. But most interestingly, he's the brains behind Oh My Sure. I think most of you have heard of it in the newspapers. He is heading the Tata Medical Diagnostics at Sri Perumbudur, which is responsible for this Oh My Sure. So we look forward to hearing more from Dr. Ravi. Dr. Ravi, we will hand over to you and we look forward to hearing from you.
Thank you, Priscilla, and thanks to CIDS. It's a great meeting. I always enjoy attending CIDS meetings. Fellow panelists and dear participants, start by sharing my screen. Just let me know if you're able to see my screen. Okay, I've been asked to talk on evolution of SARS-CoV-2 variants and challenges in diagnosis. I think these two pictures, most of you have seen a zillion times in the last 2 years. This is a cartoon of SARS-CoV-2, an enveloped positive standard RNA virus, which has on its envelope embedded the spike protein depicted on the left as a shape of a common pin with it has a globular head, which is colored yellow here, and a stem. Apart from that, it has other structural proteins like envelope, which is embedded in the envelope, the membrane protein, and the nucleoprotein which surrounds the RNA of the virus. The genome of SARS-CoV-2 is a positive standard RNA, measures approximately 29 to 30,000 nucleotides. Positive standard viruses, as you know, when the RNA is introduced into a cell, they will directly go into translation. It has a huge open reading frame, which is divided, as you can see, as ORF 1A and 1B, and then follows all the structural proteins of the virus. Moving on to variants of SARS-CoV-2. Now, this is the list of variants. As you know, viruses continuously evolve. The variants have been classified as variants of interest, variants of concern, and variants of consequence, high consequence. Variant of interest is any variant that there is alteration in receptor binding, reduced neutralization, may have an impact on treatment and diagnosis, increase in transmissibility, but not spread across globally. It is restricted to certain countries or geographic regions. The most important are variants of concern. These have very high transmissibility. That is the first property. They can present with more severity of illness. They have shown significant reduction in neutralization to the existing vaccines and reduce effectiveness to treatments and diagnostic detection failures. Now, variants of consequence, none of them have been reported so far, and they are called variants of high consequence when they demonstrate failure of current diagnostic tests, evidence for significantly reduced vaccine effectiveness, high fatality, and more severe clinical illness. We are yet to identify a variant of high consequence. Variants of concern have been the major players in the SARS-CoV epidemic over the last 2 years. They have been designated in pangolin lineage in a very complicated fashion, known as B point, 1 point, and so on. But the WHO stepped in sometime middle of last year and then reclassified them for everybody to understand based on Greek alphabets. Alpha, beta, gamma, delta, and of course the most recent one being the Omicron. You may wonder between alpha, beta, gamma, and delta why some alphabets are missing. These are the variants of interest like eta, iota, kappa, lambda. As I said, they have not spread extensively across the globe. Why do variants emerge? All RNA viruses, including SARS-CoV-2, continuously evolve. Generally speaking, RNA viruses mutate because they have a poor proofreading ability. The RNA-dependent RNA polymerase, when it copies the RNA, makes mistakes. However, with respect to coronaviruses, the proofreading ability is much, much better than viruses like influenza or HIV. Now, these changes in nucleotides are called mutations. Mutation may result in a change of amino acid or may not result in a change of amino acid. The amino acid change may be consequential if it is in a very critical site, and if it is a amino acid completely different in polarity compared to the existing amino acid, that will alter behavior. In addition, you should remember, since October last year, the virus is also under immunological pressure. Whenever there is immunological pressure in the form of vaccine responses, i.e. antibody responses, the virus also it has its own strategy to mutate. What are the implications? Most of the viral mutations, hundreds of them, keep occurring every time it replicates, have no impact because they do not result in any significant change. And the virus itself keeps evolving, following the Darwinian principle of survival of the fittest. In terms of phylogeny, the variants have used, and people have used a number of nomenclatures to designate variants. The Global Influenza Initiative for Sharing of All Influenza Data, which is abbreviated as GISAID, uses a separate classification, which I will show you. But what people use most often is based on a software known as the pangolin lineage, which is based on the following, which I'm showing in the next slide. The initial virus identified in Wuhan in January 2020 and sequenced completely was called A. It had 2 mutations, so it was classified as B. Very soon, B started dominating, and within B, there were several mutations occurring, but the parent belonged to the stem of B. So it has been classified as B.1, B.1.1, B.1.1.1, and so on. And that is the nomenclature you see most often. I must tell you, one of the first major mutations that occurred in February, March of 2020 was a change in an amino acid at 614 position from aspartic acid to glycine. This mutation is referred to as D614G. I call it the grandmother mutation that quickly took over and dominated the globe from March, April 2020 till November 2020, when the first variant of concern, Alpha, emerged. And subsequently, its history, we had Beta detected from South Africa. Alpha was detected in, incidentally, D614G was first reported in Italy, Alpha from UK, Beta from South Africa, Gamma from Brazil, Delta from our own country was first reported, and Omicron, which again was reported from South Africa. This is a genetic map depicting the mutations. As you can see, the red portion in this horizontal bar is the spike protein. Maximum number of mutations have been detected in the spike protein because it's a surface protein, that is the one that engages with the receptor. You all know that SARS-CoV-2 engages with the ACE2 receptors present on human cells. Here is a map from one of the states of India, which showed by April, May last year, among the circulating variants that were present, B.1.617, which is now called Delta by WHO, completely took over and replaced. You can see this red area in the map towards the right. It replaced all circulating strains, and it was reigning for the last 7-8 months until Omicron came along. To give you a better understanding, on the left panel, I have indicated the main changes in the various variants, the mutations. You can see Alpha had lesser number of mutations and only one major mutation in an amino acid change in the receptor binding domain. Beta had 3, Gamma had 3, Delta had 2 different mutations in the receptor binding domain that were completely different amino acid changes. And of course, Omicron has the maximum number of mutations. In spike alone, it has 36 mutations. Now, what is the implication of this? You can see the curve on the right. Alpha spread very, very slowly. It took time to spread. Beta was faster. Delta was the fastest among these 3 variants of concern until the Omicron came along, which actually, as I have referred to in an interview, is the Usain Bolt among all variants, because it spread so fast, it holds the record. You can see the curve going very, very steep in a matter of 2 to 3 weeks. That is why WHO, in a matter of 2 to 3 weeks, one South Africa reported, called this a variant of concern, although not much information was available other than its fast spread. Now, this is from the GSAID database that I downloaded this morning. Omicron is spreading very fast across the various regions of the globe, be it Europe, Africa, Oceania, North America, or Asia. And this is the geographical representation of all variants across the globe. The indigo blue is Omicron. In the GSAID, it is referred to as the GRA in nomenclature. GRA is slowly taking over. You can see GK, that is Delta, which is predominant in many countries. So Delta is still around, although I must say in most countries, the Omicron variant is taking over, as shown in this graph. This is global data. You can see the middle of November, early November, the Omicron started spreading and it's completely taking over. Until then, this entire purple patch was Delta. Now Omicron is taking over. What are the consequences of emerging variants? There are many consequences that one encounters. First is ability to spread more quickly. I talked to you about the grandmother mutation D614G. All variants of concern have this grandmother mutation in them. So that is the base on which it started spreading. At this one amino acid change helped the virus to attach better to human receptors. The second consequence we see of variants is ability to cause either milder or more severe disease. In the case of Delta, we saw a more severe phenotype. In case of Omicron, we are seeing a very mild phenotype. Ability to evade detection by specific viral diagnostic tests. I'll reserve it for the later half of my talk. This decreased susceptibility to therapeutic agents such as monoclonal antibodies. We are seeing that with Omicron now. The available therapeutic cocktails globally are failing to neutralize the virus completely, although there is one cocktail which Ram can tell you later is available only in the US that is supposed to act efficiently against Omicron. And of course, the biggest concern has been the ability to evade natural or vaccine-induced immunity. I'll move on to the second part of my talk, which is on the challenges in laboratory testing related to variants. It's always been a big challenge, whom to test, when to test. I think whom to test, we all know. In the first 7 to 8 days, there's a huge rise in virus as well as antigen in the nasal and throat cavity. Antibodies, for some reason, appear very late in SARS-CoV-2. IgM and IgG don't appear to detectable levels until it's 7 to 10 days. So they have very little utility. And whom to test? The WHO has given this guidance a few days back. It strongly recommends, at least for Omicron, tests for healthcare workers and those who are symptomatic and admitted to a hospital. This slightly lower priority is for people who are in clusters, and the least priority is for routine testing or tracing asymptomatic contacts. The second biggest challenge the variants pose is related to any laboratory diagnosis. If sample collection and storage is well done, then you will have less problems with the accuracy of the test. And of course, antigen-based tests are useful in symptomatic patients, the main method, initial method of detecting variants is sequencing. The mainstay of diagnosis remains molecular tests. Molecular tests are also have their own limitations. They are best positive between 1 to 2 days after onset of symptoms, and within the first 7 to 10 days, they have their highest level, and detectable levels are achieved in this window. The FDA advisory on impact of variants on molecular tests, because that is the mainstay. The FDA warns that you should be aware of target failure or gene dropout. What is target failure? Whenever molecular assays use the S protein gene amplification, it can be missed. If assays don't use it, then the chances of gene dropout and a failure in the test is much less likely. So S gene dropout, and of late even N gene dropout, is being talked about as a surrogate marker for detecting Omicron in clinical samples. A gene dropout may occur due to different mutations, and I will touch on this in 2 later slides. In terms of the impact on antigen diagnostic tests, the WHO has said that it has very less impact. How did they do it? They took clinical specimens, heat inactivated it, and there's an NIH team that continuously monitors available rapid tests. And so far, they have not found any major impact on, because most antigen detection tests are based on the detection of nucleoprotein antigen. However, the FDA warns that it is not a replacement to live virus. Testing at airports is a huge challenge when it comes to variants. Countries impose this. People want quicker results and to get out fast. I'm going to end in the next few minutes by talking to you about Omicron, a test that was developed by my team and me at Tata Medical Diagnostics at Sriperumbudur. I'll just tell you the journey. On November 26th, Omicron was announced. December 1st, we sat together and we applied our minds and did a huge bioinformatic exercise. By 7th, we had identified primers and probes that are unique to Omicron. December 20th, we had got the reagents. We did not have a single clinical sample when we developed this test. So we developed a synthetic gene of the entire spike protein of Omicron and standardized the test on it. By December 23rd, we decided to file a patent application. December 26th, we assembled the kit and submitted to ICMR for validation. December 30th, ICMR validated the kit. 1st January, I developed symptoms of COVID, and I sent my sample to Sriperumbudur, and it turned out positive on Omicron and indicated Omicron. 4th January, we got the license to manufacture. And right now, we are battling. We are battling issues related to availability of raw material. The conventional method of detection of any variant, especially Omicron, is to do a PCR. If the PCR is positive, CT values less than 25, it can be sent for sequencing. Now people are using S gene target failure assays, mainly the Thermo Fisher one, as a surrogate marker. So our assay directly detects Omicron specifically. How does it do it? It uses 2 strategies for the first time globally. One is to amplify a region where the S gene has mutations. So we have incorporated S gene target failure. However, this region is different from what other assays use. Most of the other assays use 69, 70 amino acid deletion, and that is reverting in Omicron, and they are called stealth Omicrons. We are stealth Omicron variant proof because our region is entirely different. Secondly, we identified a section in the spike protein that has many mutations unique to Omicron, and it is conserved in all genomes that we amplify and detect using a probe. And lastly, we have a RDRP gene, again conserved in all variants, which we amplified to detect the variant. This is the ICMR validation report. ICMR did a validation with 85 SARS-CoV-2 negative samples. In our assay, they got concordant results. 88 sequence samples, among which 40 were Omicron, and all these were detected both by dropout as well as the S gene specific mutation amplification. 35 Delta, they did not have S gene dropout, so they were sequence samples, and 13 other variants. So the sensitivity for Omicron detection according to ICMR based on this evaluation was 100% for all Omicron variants, and 99.25 specificity for Omicron, because there was an interpretation issue which we have corrected subsequently. Whereas for all other SARS-CoV, it is 100% sensitive and specific. It can be used on nasal and oropharyngeal swabs. In VTM, we have not evaluated on other media. RNA extraction is required. Amplification is 85 minutes, and result interpretation follows a chart. We believe this test can be used, according to us, for hotspot detection in newer areas. It can you can result in shorter isolation, give relief to patients, and help clinicians predict risk of severe symptoms and avoid antibody therapy. Lastly, these are the available tests for Omicron detection. Omicron is the only test that uses S gene dropout and S gene specific mutation combined for the first time, and it can detect other variants as well. The final slide, we are doing continuous variant watching. Every day, one of my team members downloads all sequences from the GSAID database and looks at the impact on our primers and probes. Touch wood, so far we have not any issues, but we have anyway got a second set of primers and probes. In case there's a problem, we'll be able to do it. Thank you very much.
Thank you, Dr. Ravi, for that absolutely fascinating talk. And I can see that there are a number of questions already in the chat box, but we will reserve the questions for the panel discussions. So we look forward to Dr. Ravi answering those. So please don't go away. We have a very interesting panel discussion towards the end. We will go ahead with the next lecture. It's my pleasure to introduce Dr. Ram Gopal Krishnan. Dr. Ram Gopal Krishnan is one of the founding members of the Clinical Infectious Diseases Society. He is an infectious disease physician at the Apollo Hospital at Chennai. He is a prolific researcher. He's been a mentor to so many ID physicians in the country. Dr. Ram Subramanian will be talking to us about the clinical features and the modified treatment modalities with regard to Omicron. I'm going to ask Hallmark to actually play the recorded lecture. Dr. Ram kindly had recorded that for us.
Give me a minute while I share my screen. Right, so this is my topic today, the clinical picture and treatment modalities during the Omicron wave. And I'll be spending about the next 20 minutes or so on this. Whatever I'm saying will be specific to Omicron and not COVID in general. These are my disclosures. I have no financial interest in any company making any of the drugs discussed. And I have received, I've been involved with these companies, all for non-COVID related therapies. So first of all, how does Omicron behave? Is it different from previous variants? A couple of papers have addressed the presentation of hospitalized Omicron. This one from South Africa compared what happened this time, November 15th onwards, to their 3 previous waves. They had the ancestral wave, then the beta, and then the delta wave, and now Omicron. And they looked at hospitalized patients so that you could have a uniform baseline to compare patients with. What they found was that current wave with Omicron involves younger patients with fewer comorbidities, fewer hospitalizations and respiratory diagnoses, and a severity is actually decreased in these patients. And this table illustrates some of these points. You can see here that the median age was lower compared to previous waves. The number of comorbidities was also less. And acute respiratory condition, essentially a surrogate for oxygen requirement, was 31% compared to higher numbers during previous waves. If you look at actually patients receiving oxygen therapy, just about 17% of patients got oxygen therapy compared to 74, 82% in previous waves. Similarly, a very low percentage of patients got on the ventilator. Admission to ICU was similarly lower. All of these were statistically significant. So it truly seems that Omicron behaved less virulently compared to previous variants. The second paper, which is available only as a preprint, came from Southern California, where they looked at a large database of patients who tested positive in the outpatient, and they used this S gene dropout as a surrogate marker for the presence of Omicron, kind of what you and I in practice would be doing rather than sequencing, which is not available to us. So after an outpatient positive test compared to Delta, Omicron had roughly about a half-fold likelihood of a symptomatic hospital admission. The duration of hospital stay was reduced by 69%. The chance of going to the ICU was much less, just a quarter, and mortality was just less than 10%. And no patient went on the ventilator as compared to 11 patients with Delta variant. So the conclusion of this paper was that Omicron substantially reduced the risk of severe clinical endpoints compared to Delta infections in terms of severity of COVID. So they could do this comparison because they have two strains circulating at the same time in the US, kind of similar to what we have here in India. So how does Omicron behave in comparison to other clinical variants? You will note that there are no references on this slide. A lot of this is kind of experience and what others have experienced. There is a higher propensity for reinfection that was shown from South Africa. It is very transmissible early on, but maybe less so after the first 5 days compared to previous variants. The incubation period is also shorter, 3 days rather than 5 days, and it tends to attach itself to the upper respiratory tract. There are in vitro experiments showing this rather than the lower respiratory tract, especially in patients with previous vaccination or prior infection by other strains. It tends to behave clinically more like a URI rather than pneumonia. It's very difficult to tease out what part of this is the virus and what part of this is the host immunity, what part of this is vaccination. There seems to be much less loss of smell and taste compared to previous variants, and other symptoms are really indistinguishable from other respiratory viruses. So you really have to either test for it or know your epidemiology to pick this up. It also seems to get better quicker, and CT scans also show less prominent findings, perhaps consistent with its localization in the upper respiratory tract. So in other words, it behaves more like a classic coronavirus, the ones which were described 50 years ago, rather than the newly discovered and described viruses over the last 20 years or so. So how would you treat Omicron in the OP setting? This is where we would largely encounter Omicron because it tends to be a milder disease. First of all, on the report, look for an S gene dropout. If your lab is not doing a kit which has which looks for the S gene, you will have to infer it from epidemiology, whatever is going on in your city or town. We know that a large proportion of what is going around is Omicron right now. Elicit carefully the vaccine history. This now becomes the most important part of the history in a COVID patient. The definition of vaccination, remember, is 2 weeks after the second dose, and elicit a history of past infection during earlier waves. The problem is we don't have any Omicron-specific clinical data for any of the available therapies. So whatever I'm telling you on is based upon therapies for other variants which tend to cause more severe disease. We also don't have data on therapies for vaccinated patients. So this is, again, a blind box. Perhaps vaccinated patients don't need any therapy at all. The vaccine immunity itself takes care. So use primarily symptomatic treatment and reassurance for a proven outpatient with Omicron. And if you're going to intervene, prioritize unvaccinated patients for therapies. These are the people who actually get into trouble, may end up in the hospital where it behaves like classic COVID. Obviously focus on those with comorbidities, the elderly, known vaccine responders, which is kind of equivalent to unvaccinated or the immune compromised host. And don't waste your time on things like CRPs, D-dimers, or CT scans. These are all completely unnecessary for all COVID and certainly for Omicron. Avoid unproven or costly therapies. You don't want to make the treatment worse than the disease. And there's a saying that in an emergency, don't just stand there, do something. Rather, for Omicron, just stand there. Don't just do something. Just stand there and watch it get better on its own. So these are some of the therapies we have available for the mildly ill outpatient at high risk of progression. What is perhaps more important and relevant is what not to do. The interventions that won't help. These have all been shown in large randomized double-blind controlled trials. Drugs like azithromycin, ivermectin, doxy, all the vitamins are really quite useless and should not be on your prescription. There should be a long list of symptomatic treatments on your prescriptions because these patients have a lot of body ache, headache, throat pain, etc. They may be coughing. So fill up your prescription with all these symptomatic treatments so the patient walks away satisfied. And these are the other therapies which we'll discuss in a minute or so, which you could potentially consider for Omicron. Whatever you're going to do, do it early. It's well known that the action in Omicron takes place very early, almost yesterday or the day before, and it's rapidly, it's gone non-culturable within 5 days. So if you're going to give an antiviral, you've got to give it early, not late. If the patient presents late, forget about antiviral therapies. Now, this is the Stoic trial on inhaled budesonide. It's somewhat dated, and this was the follow-up principal trial, a larger trial showing that soft endpoints like hospitalization were reduced. On the basis of this, budesonide was favored. But let me ask you this: if with usual care you moved up your graph to 75%, so perhaps usual care is better than inhaled budesonide, and we know that recovery rates are much higher with Omicron. So we really don't know whether inhaled budesonide is useful for Omicron. Yes, it seemed to be useful for previous strains, but we don't know that for Omicron. So there's a question as to whether you really need to use this drug for COVID due to Omicron. Monoclonal antibodies have been popular in the last 6 months or so. Obviously, high-risk patients are candidates, age above 60, those with comorbidities, and they really work only early before antibodies form. There are 4 monoclonal antibodies out there in India and abroad. This is the only one available in India, cassidymap plus imdevimab. You have to start this very early. It definitely won't work after a week. It preferably started very, very early. It works against the past variants, including Delta, but the company themselves have done studies admitting that this does not work against the Omicron variant, diminished potency, and not recommended by the company itself. So this is off the table if you have a proven Omicron patient. Sotrovimab, on the other hand, is available abroad. It's not available in India. It has good randomized double-blind clinical data available, showing that you dropped your risk of hospitalization or death from 7% to 1%, 85% reduction is quite reasonable. It is active against all the prior circulating variants, and it probably retains activity against Omicron as per company. So watch this space. If this drug comes to India, it should certainly be useful. The other drug which is available abroad, again, not available in India, is this drug with a little difficult to pronounce name, pixar, silgavimab. Well, this is not really a drug which is used for post-exposure prophylaxis. It's a long-acting drug. And the main use is if you give this to somebody who's immune compromised or who doesn't have antibodies or who won't respond to vaccine, somebody who's had an anaphylactic reaction to vaccine, you protect them for about 6 months or so. The company says that it does have neutralizing activity against Omicron. That's the reason I put up this slide. And if this comes to India, it's a potential option for some of our severely immune compromised patients. Again, it's not useful for treatment or post-exposure prophylaxis. So what is very topical now is Remdesivir. I'm not sure if I should call this a repurposed drug or not. We're also used to using it for COVID. Sounds like a repurposed drug, but not a relatively new one, just devised a couple of years ago. And what got us excited was this randomized double-blind trial in the New England Journal of Medicine looking at unvaccinated patients. That's a very, very important group of patients. They all had the original strain or alpha, not even delta. So this is really quite a dated study, and they all had risk factors. But what was interesting was they used the drug on these patients the way an antiviral should be used right away. They started it as early as possible within the first 5 days. And it's just a short course of Remdesivir, 200, 100, 100, just a 3-day course. And they demonstrated quite an impressive drop of hospitalization of death from 5.3 to 0.7%, about 87%. So well done trial showing that early Remdesivir does prevent progression to severe COVID-19. These are the number of patients who were hospitalized. But once again, if I turn that around and say that with placebo, the number of patients who will be hospitalized due to Omicron is actually here, closer to the Remdesivir curve. We know that Omicron behaves much less virulently compared to certainly the D614G strain. Then perhaps Remdesivir won't benefit these patients. So that's an unanswered question with this particular drug. And in fact, with all therapies for COVID we have right now. The subset analysis showed uniform benefit, including diabetics, obesity, etc., in favor of Remdesivir. And so looking at this study, you can say that it's studied only in unvaccinated. So it's very fair to use it in that population. Still, at least a third of the country is unvaccinated. It is certainly effective against past variants. We don't have any data against Omicron. It should work, but whether it works better than placebo, we don't know. The problem is it's an intravenous drug. There are efforts on to make an oral formulation, but that's a long way off. And so if it's a parenteral shot, you either have to admit the patient or you have to get them back 3 times in a row with all the attendant risks of spreading COVID, etc. So that's a big problem with this drug. It's clearly safe. We have a lot of clinical experience with this drug. And at this point, at least to me, it looks like the drug of choice for the high-risk unvaccinated patient. And also for the vaccinated, but perhaps a non-responder, perhaps a very severely immune-compromised host, you could consider it. Again, this is off-label, but you could consider the drug since it does show a reduction in clinical endpoints. Monoprover is the latest kid on the block. It's an oral drug. That's a great attraction. Specifically, it also has a high genetic barrier to resistance, fairly high pill burden, and this unfortunate potential mutagenicity, carcinogenicity, genotoxicity. None of this is in humans, not enough studies, but all of this is something that is out there about this drug. We really don't know, only time will tell. This drug is approved in India for use by clinicians, largely based upon the Move Out study, which looked at unvaccinated participants. So once again, applicable only to that study population. They were all Delta infected. So I can't tell you whether this will work against Omicron or not. Being an antiviral, it should, but again, we don't know versus placebo. What is very important is it's not a great drug. It drops your risk of hospitalization or death from 9.7 to 6.8%. That's just 3%. So that's not a lot. And the relative risk reduction is 30%. Even Remdesivir does 87%. And this is actually quite fragile. If you look at these confidence limits, perhaps 1 or 2 cases that side, and you might not have got statistical significance. So there are a lot of issues with this drug. The biggest attraction is it's oral. If you look at the subset analysis, clearly those who had antibody positives at baseline, past infection, vaccinated, it did not benefit. You can see this is across the mean. So it's only useful for unvaccinated patients. Obese patients, it seemed to do well. Diabetics, strangely, if your sole comorbidity was diabetes, you didn't seem to benefit from this drug. So kind of some interesting facts in this subset analysis, which is always fraught with risk. So in conclusion, Monoprover is studied only in unvaccinated. So please use it in an evidence-based fashion only in that group. It's not a great drug, much less than other therapies. It seems to work better in females, obese. If you're COVID antibody negative, probably does not work if your sole comorbidity is diabetes or if you're antibody positive. I would avoid it in all women. It's a big headache, this maintenance of contraceptives, both to the woman as well as the male partner. Just too much of a headache in the outpatient in a busy COVID OP. Just avoid it for women of childbearing potential. We don't know about Omicron at all. And even in the US, they say use it only if no other options, as I'll show you in the next slide. My opinion, really drug asking for a disease at this point. This drug, on the other hand, looks far more promising. This is Remdesivir. It's a protease inhibitor. Those of us in HIV medicine are quite used to this class of drugs. Innumerable drug interactions, and you'll have to give ritonavir boosting. But it's quite an effective drug. You can see here that it drops your risk by 89%, the same, similar to Remdesivir. So it's a pretty good drug if you start it very early, especially if you give it immediately after your COVID test, within 3 days of symptom onset. It seems to work up to 5 days as well. And there were no major safety endpoints. And on the basis of this, it is available in US and other Western countries. These are US guidelines. I just put this up there just to compare some of these drugs that are available. Note that Monoprover just gives you a 30% drop in reductions or death. All the other therapies for COVID are 70, 80, almost 90. So clearly, it's less efficacious compared to the others. And activity against SARS-CoV-2 variant, the one monoclonal antibody we have here, Omicron variant, unlikely to be active. So the one monoclonal antibody we have in India doesn't seem to work. So these are US guidelines, but what can we infer from these in our Indian situation? Busy slide. But this is basically patients who are sick with COVID. You manage them as you do currently for past variants. If you have impaired liver or renal function, sotrov seems to be useful. Again, not available to us Indian clinicians. And for the average early presenter, 3 to 5 day high-risk presenter, they recommend either Remdesivir or sotrov, neither of which are available. So basically, you are stuck with Remdesivir. And only for some reason, if you can't give Remdesivir, should you even consider Monoprover with all the caveats of teratogenicity, etc., etc. Moving on to the moderately ill patient. By the time your patient is hypoxemic and in the hospital, it's probably too late for antivirals. So you'll have to stick with dexamethasone. Increasingly, we are using therapeutic anticoagulation in these patients, especially if their D-dimers are high. And cassidymap, again, no role for Omicron. So if this is an Omicron talk, that should not even be on there. And the usual questions, nothing's new in this area. Does Remdesivir work at all? WHO says no. Western guidelines say yes. And clearly what doesn't work, again, nothing new on the right side of the slide. The usual suspects that don't work in moderately ill COVID. Similarly, in the severely ill patient, the one in the ICU, requiring large amounts of oxygen, you don't have a lot of choices available to you. This pictorial points out that later on in the disease, when you're hypoxemic, it's largely steroids with or without tocilizumab or baricitinib. WHO recently endorsed baricitinib, so you could call that poor man's tocilizumab, but none of this is specific to Omicron. This is for COVID in general. So this is my hospital's protocol. On the left side in green are mildly ill outpatients. We discourage CT chest for these patients. And the drug of choice, if it's an unvaccinated patient, we would give them Remdesivir, either admit them and give, or as outpatient infusions. Cassidymap only if we are sure it is not Omicron. We don't use the drug unless we have ruled out Omicron. S-gene detected, in other words. And I have put optional inhaled budesonide and Monoprover on there. Having said that, I have yet to use Monoprover in a single patient, and I'm using less and less budesonide with Omicron because you may not even need it. These therapies for moderately ill and severely ill patients are no different from COVID in general. Dexamethasone, anticoagulation, which often is therapeutic for the mildly ill or the ones on low flow oxygen. You use cassidymap only if you're sure it is Omicron and you know they are seronegative. Remdesivir, again, questionable, perhaps for the very early presenter on low flow oxygen. And for severely ill patients, again, dexamethasone, you proceed rapidly to tocilizumab within 24 hours if they get worse, occasionally antibiotics. And if they can't afford or if you can't use tocilizumab, you would consider baricitinib. So this is my concluding slide on Omicron. Omicron is largely a milder illness that requires symptomatic treatment in non-hospitalized patients without comorbidities or if vaccinated. Antiviral drugs to be considered largely for the unvaccinated host. Remdesivir is the most effective agent, but parenteral administration required. Monoprover probably has no role for these patients. Selected unvaccinated patients with extensive comorbidities or immune compromise may benefit. Cassidymap, Remdesivir doesn't work. Sotrov and Monoprover look promising, and the treatment of moderate and severe COVID due to Omicron is unchanged. I would like to thank my second-year ID fellows. Just as they were recovering from the first waves, they've been hit by this last wave. Thank you very much. Thank you. I will stop sharing here.
Thank you to Dr. Ram Gopal Krishnan for that wonderful informative lecture. Indeed, it's been a trying 2 years, and it's a difficult one for most of our postgraduates as well as fellows. So we'll go on to the third talk right away. I see there are lots of questions in the chat, and we are trying to have enough time to answer most of those. So without further ado, we'll go on to the next talk, which is Omicron and the impact on our vaccination drive. So it's my pleasure to introduce Dr. Gagandeep Kang. Dr. Gagandeep Kang is a professor of microbiology at the Christian Medical College, Vellore. She is part of the Wellcome Trust Research Laboratory that is based in CMC, Vellore. She is the vice chair of the board of Coalition for Epidemic Preparedness Innovations and a Wellcome Trust nominated member of Hillman Laboratories, which is a partnership that supports development of affordable vaccines for low and middle income countries. She's also part of the WHO group, which is the strategic advisory group of experts which decides on vaccines. Of course, all of you do know she's also one of the first Indian women to be elected into the fellowship of the American Academy of Microbiology and only physician scientist to receive the Infosys Award in Life Sciences. So over to you, Cherry, and thank you for agreeing to give us this lecture.
Thank you very much for the introduction, Priscilla. I'm going to take us rapidly through Omicron and vaccination. I think when we think about vaccination, it's important to remember what the goal was when we started out. WHO had come up with a values framework which said that COVID-19 vaccines should be a global public good, and that the goal of vaccines was to contribute to equitable protection and promotion of well-being among all people of the world. What you see below is a map that shows you where the unvaccinated people are. And if you look at which country has the maximum number of unvaccinated people, despite all the successes of our program, we have to remember that India's population is truly humongous, and we do have populations in remote areas that have not yet been protected by vaccination. Now, if we look at the principles that were laid down, and this is important when we come to discuss boosters, I'm not going to walk you through all of the principles, but it was essentially around human well-being, reducing deaths and disease, making sure that everybody had a chance of getting vaccinated, that we looked after global and national equity and made sure that when we prioritized within countries, we took into account the vulnerabilities and needs of different risk groups. And this is important in the context of discussion of vaccination of children and the booster doses that have been included. Reciprocity is the principle by which healthcare workers who take on additional risk burdens also are front of the line when it comes to getting vaccinated and boosted. And then, of course, is legitimacy of looking at doing this as a global community. Now, I'd like to this is not about vaccination so much as an update on where things are in South Africa. If you look at the waves in South Africa, you can see that in their fourth wave, cases have started to come down. But if you compare cases and deaths as shown in the graph below, what you're seeing is that while cases may be comparable, the deaths are at approximately 30% of where they were with Delta at a similar stage in the wave that was Delta-driven, the third wave. Now, what does this mean in terms of vaccination and infection? South Africa as a country has relatively high levels of infection. About 60 to 70% of people, it is estimated, have been exposed through the first three waves, and their immunization coverage is actually lower than that which has been seen in India. If their deaths are at 30% of Delta, if they weren't able to roll out a booster program in their population at any significant level, what is the mitigation that we should expect from the booster program that is being rolled out in India at the moment? In my own inference, I think we are going to follow the South African pattern, and the value of the boosting that we are doing currently might wind up being actually quite limited for the Omicron wave. If we look at the current status of vaccination in the world, about 60% of the world's population has received at least one dose of the COVID-19 vaccine, and this is total population, not eligible population. About 9.6 billion doses have been given out globally, and about 34 million doses are given every day. But only 9.5% of people in low-income countries have received one dose, and there are at least 30 countries in the world where less than 10% of the population has received one dose of vaccine. If we look at where we are in terms of the doses given and the share of people that have been immunized, you can see that India is ahead of the global average in terms of the proportion of the population that has been vaccinated. If we look by number of doses, of course, China has given out 2.9 billion doses of vaccines, India at 1.5 billion. Important to remember that there are no other countries except India and China that need to give out more than 1 billion doses of vaccine. And if we look at coverage by percentage of population covered, you can see that Cuba and Chile and UAE lead, but we will catch up with time. And that's one of the good things about the Indian program. Our numbers are large, but our program moves ahead steadily. Now, what I'd like to share with you over the next few slides is data that was released in the UK yesterday, which is data on vaccine effectiveness against the Omicron variant. And what is shown in this graph here is what you see with 2 doses of the ChAdOx vaccine. This is a test negative case control design for vaccine effectiveness that compares the Delta and the Omicron variant. Omicron is shown as the gray circles, Delta is the black boxes. What you can see is that with 2 doses of ChAdOx vaccine, the vaccine effectiveness declines with time, and this is against symptomatic infections, not hospitalizations. So much so that about 25 weeks after vaccination, you have practically no vaccine effectiveness against symptomatic infection left at all for the Omicron variant. And it's at about 40% for the Delta variant. However, when you give a booster with, and in the UK, they're using mRNA boosters, either Pfizer or Moderna, that pushes up the rate, the effectiveness of the vaccine. You get protection against symptomatic infection. And after about 10 weeks, that declines as well. These are data that are based on a period from when the Omicron variant came into the UK until the 6th of January 2022. And it compares about 250,000 Delta cases with 750,000 Omicron cases. So you can see the data there for the AstraZeneca vaccine. And then if you look at what happens with the Pfizer and the Moderna vaccines, you can see that the vaccine effectiveness against symptomatic disease also declines. In the case of Omicron, it goes below 20% for both Pfizer and Moderna about 25 weeks after vaccination, whereas with Delta, it is preserved at about 60% for Pfizer and about 80% for Moderna. Again, when you give a booster dose, the third dose of vaccine, then that pushes up the protection once again. Doesn't seem to last very long in whatever we have seen, somewhere between 10 to 12 weeks, it comes down again. Remembering this is symptomatic infection. Moving now to protection against hospitalizations. This table has a lot of data in it. So what I suggest we do is focus really on the first and the last columns. The first column is the number of doses that people have received. And in the next column is the duration after which this period of study starts. And the last column shows vaccine effectiveness against hospitalization. So if you look, single dose protection, and here all the vaccines are clubbed together, AstraZeneca and Moderna and Pfizer. Vaccine effectiveness against hospitalization with the single dose, 58%. If you receive 2 doses, up to 24 weeks, 64%, drops to 44% if the period goes beyond 24 weeks. If you give a booster dose, then protection is high at 92%, and at about 10 weeks following the booster dose, it has come down, protection against hospitalization, to about 83%. So in general, the booster dose does result in an increase in vaccine effectiveness against hospitalization, but we do have to be aware that this will decline with time. Now, these data club together all of the vaccines, and they also do not stratify based on age or on comorbidities, and the data for those should emerge in the next few weeks. There is another study that the UK does, which is very useful to look at, and this is the SIREN study, started early in the pandemic. This is 44,000 healthcare workers who are screened for infection every 2 weeks. 30% of them were seropositive at baseline. 95% are vaccinated, and what we are looking at here is infections on top and reinfections below. And you can see that Omicron is really driving infections and reinfections. Now, if we look at the SIREN study and what's happening with vaccination and infection in the SIREN study, what we see, if we compare unvaccinated populations, so in the top part of the table, what we've got is unvaccinated people that have not been infected previously. And in the bottom part of the table, we have unvaccinated people who have had prior infection. If you look at protection from infection in this group, you see that there is a small amount of protection that is obtained from infection. So unvaccinated, previously infected, 44% vaccine effectiveness. And if you look at what happens with vaccination, that pushes it up with 2 doses to about 60%, and with 3 doses to 71%. If you have not had an infection and you have been vaccinated with 2 or 3 doses, vaccine effectiveness in this cohort is 32 and 62%. So it does look like infection acts like an extra dose of vaccine. And the best situation for protection is really in people who have been infected and have received all their doses of vaccines as well as boosters. So this repeated antigenic stimulus does matter. Now, if we look at Omicron and what happened in the early days, one of the worries about Omicron was not only that there were so many mutations, but also very quickly, the data that appeared that showed that there was a dramatic drop in the ability of the virus to neutralize, to be neutralized by sera from people who had been infected or vaccinated before. And shown here is the graph from people who had received the Pfizer vaccine. And if you look there, you see that if you had infection plus vaccination, you maintained some level of neutralizing antibodies, whereas if you had been vaccinated alone, the neutralization levels were much less. We know a lot more now. And if I draw your attention to the figure that is just the colored dots on the bottom right-hand side of the slide, this is antigenic mapping or antigenic cartography from Gavin Screeton's lab, and it kind of explains what we are seeing with vaccines. If you look at the Wuhan strain, Victoria, etc., you can see that the alpha strain, alpha variant is very closely related antigenically to the Wuhan strain. Delta in the bright pink is off to one side, and beta and gamma are off to the other side. But look at where Omicron sits. Omicron is very, very far away from all of the other variants. So what does this really mean is something that is being dissected by scientists right now. They've done the work showing what happens if you've been vaccinated with different kinds of vaccines, shown here, multiple types of vaccines, and the reduction that is seen in the neutralizing ability of sera from people who have received those vaccines against the alpha, beta, gamma, delta, and Omicron variants. And what you can see here is that there is a reduction that is shown in the table as well, which shows that with all of the vaccines, and there have been a lot of studies, particularly for the mRNA vaccines, there is a large reduction in the ability of sera from individuals to neutralize the Omicron variant. Now, this is has been seen even in people who have received booster doses. It's there is neutralizing ability, but whether you receive 2 doses or 3 doses, Omicron is a variant that has large-scale immune escape. We've also had data from Gavin Screeton's lab, where they have an interesting set of samples from people who were infected with different variants at different points in time. So in A, you have people infected early in the pandemic, so the grandmother mutation, as Ravi said. People in B, C, D, and E who have been infected with alpha, beta, gamma, delta. F has people who received vaccine and were infected with delta. And what you see here is Omicron is shown here in black, the other variants in different kinds of colors. You can see that the neutralizing ability in people who have been infected has generally been much, much less for Omicron. If you are both vaccinated and infected, then your neutralizing ability for Omicron is a little bit better than if you were infected alone with one of the earlier variants. If you look at what happens when you give a third booster dose to individuals, what you see is that neutralizing antibodies go up for all of the variants, including for Omicron. And this is reassuring and is one of the reasons why we are seeing a push for inclusion of of booster doses for while we have the Omicron variant. Of course, timing matters. So there are data that have been reported in the news. So we have data from the UK with the Covishield study showing us that 3 doses of Covishield vaccine do drive up the immune responses to Omicron, and you get better neutralization. Of course, it's better with the mRNA, but at least with Covishield 3 doses, you do see good neutralization of Omicron. And then we've had also a news report about Covaxin, where from their phase 2 study, they identified individuals, boosted them 6 months later with another dose of Covaxin, and these sera were tested in a neutralization assay. And while this data is not available in preprint format yet, it has been reported to show that there is an improvement in neutralizing ability in these individuals for Omicron. We also have recent data that has just come out this past week looking at T-cell responses. And essentially what these data show is that T-cell responses are preserved against Omicron. It's been estimated that 90% of epitopes continue to be recognized, and that somewhere between 70 and 80% of the activity, T-cell activity, is also preserved. One of the questions that has been raised is whether the mutations that we are seeing is actually pushing the Omicron response to be something. We've seen the antigenic cartography that puts Omicron at a distance from ancestral variants. But if you combine both the T-cell responses as well as the antibody responses, what you see is that the kind of protection that has been induced that protects against Omicron seems to be resembling much more the ancestral variant. So just to summarize, Omicron has led to an emphasis on booster doses, but from South African data, it's unclear whether boosters are or were really needed to make a difference at the population level. We do know that a third dose of vaccines boosts neutralizing antibodies. We have real-world evidence that shows that a third dose contributes to reduced hospitalizations in the UK. Based on the totality of evidence, it seems like boosters for priority groups can be justified at this time, but we still do have a lot to learn. Thank you for your attention.
Thank you, Sherry, for that absolutely fabulous talk. And I think there are more than 30 questions regarding vaccines in the chat box. But what I'll do is we'll go on to the most exciting part of today, which is the panel discussion. It's my pleasure to introduce the additional 2 panelists, apart from the speakers who have kindly agreed to stay back. Dr. Tanu Singhal. Dr. Tanu Singhal is a pediatric infectious disease physician from Kokilaben Dhirubhai Ambani Hospital in Mumbai. She has more than 20 years experience with infectious diseases, and she's actually written a very interesting article on Omicron in the Indian Journal of Pediatrics. The other panelist who has joined us is Dr. Senthil Nambi. Dr. Senthil Nambi was my predecessor. He was the secretary of the Clinical Infectious Disease Society of India. He's an infectious disease physician at the Apollo Hospital in Chennai. In addition, we'll have the speakers as well, and I'll hand over to my president, actually, Dr. V. Ram Subramanian, to take over as a moderator for the panel discussion.
Thank you very much, Priscilla. We have had a very interesting 1 hour here, and at the end of it, still I'm left a lot confused, and I hope the next 45 minutes or so of our session will give us some answers. I'm going to start with a quote from John F. Kennedy, who said that for the great enemy of truth is very often not the lie, deliberate, contrived, and dishonest, but the myth, persistent, persuasive, and unrealistic. We subject all facts to a prefabricated set of interpretations. We enjoy the comfort of opinion without the discomfort of thought. I mean, I think this is perfectly suited for the current scenario of this pandemic. And we have a lot of questions lined up. I know Dr. Ravi has to leave. I promised I'd leave him by 7:15 to 7:20. So he has answered a lot of questions which have been raised after his talk, but I'm going to only highlight the 3 or 4 questions which I think he will answer before he leaves. One, I wanted to stress, somebody had asked the importance of antibody testing, and he very clearly said the role of antibody testing is restricted to detection of suspicion and diagnosis of multi-system inflammatory syndrome, especially in children. Otherwise, it has no role. Would you agree, Dr. Ravi? Do you have anything to add?
Yes, that is my response I put in the chat box. That is my understanding of antibody as a detection tool for diagnosing COVID. In MISI, what happens is, we all know 2 to 3 weeks after acute COVID infection, which may be asymptomatic quite often, they will come up with this typical Kawasaki type of presentation. In that time, the only way you can diagnose is by detection of antibody. Having said that, with the advent of pediatric vaccination, even that antibody detection, I believe, will have very limited value. Over.
Thank you. One more question asked is, does biotin supplement interfere with the testing of PCR? Does it cause false positive tests?
What supplements? I didn't get that.
Biotin.
Biotin supplements.
Yes.
No, not that I am aware of. They do not interfere with PCR in any way. Oh.
Right. Another question is, can the pre-existing strains re-emerge? In other words, can we get the Delta to replace the Omicron in the coming months, or Omicron, which has the virulence of the Delta? Is that possible?
One thing I've learned in 2 years is not to give a definitive answer. So I'm going to be evasive. I'd say highly unlikely.
Okay, so not even, we don't want predictions, at least speculations?
I wanted to start a company called Viral Astrology. When Omicron came, I gave up that option of a startup.
Thanks, Dr. Ravi. Then one last question. We have a lot of problems in identifying infectivity. So far, we have said 7 days after a positive test is okay. But you can understand in practical terms, it is very difficult in a lot of situations to be waiting for even 7 days. So is there any test, for example, the PCR doesn't tell us that if it is a live or a dead virus. So is there any test in the pipeline which can tell us that we do the test, it is positive, but it is all dead. So you can, don't worry and carry on. Is there anything like that available?
There has been a research tool known as subgenomic amplification of the nucleic acids, which never saw the light of day as a diagnostic test. People use that as a more reliable marker of replicating virus compared to dead virus. But nobody has ever developed such a test. Broadly and very loosely, antigen is a marker of virus replication. So antigen tests can play as a surrogate to say if somebody is currently shedding live virus or not, with a pinch of salt, of course. But that's the nearest we have. Over.
And one more question which was asked, I think you've answered, is, are rapid antigen tests useful for detecting Omicron? And you have said, yes, they shouldn't be, the Omicron shouldn't interfere with the testing capacity. Correct?
I alluded to the FDA advisory. FDA continuously monitors all rat tests and they use heat inactivated clinical specimens. And although nucleoprotein is the protein detected in antigen tests, does show mutations, it doesn't seem to impact the antigen detection by the monoclonals used in the assay greatly. So that is the current understanding we have. With SARS-CoV, anything may change overnight. Over.
Okay, thank you very much. I think it is 7:20, and as promised, I'm going to, give you the freedom. I think we understand perfectly. Thank you very much for joining us this evening.
And I'm really sorry to be so rude, but as I said, I'm battling production issues. I'm off to the lab for a night out. Thank you very much.
Thank you, sir. Now, I would like to welcome Dr. Nambi and Dr. Tanu Singhal also to join the panel. And I'm going to start with a question probably for Dr. Nambi. Do you think screening of asymptomatic patients prior to surgery is warranted?
Probably depends on two reasons. One thing is risk of transmission to healthcare workers in a hospital setting. Other one is the nature of surgery per se. So I think I would probably suggest continue to screen patients, even though they are asymptomatic, prior to any major surgical procedure, because we are through for a major wave right now. I know that the ICMR advisory has said clearly not to test, but I have a different opinion. Just because we are through a major wave and we are not seeing it abating for the next 6 to 8 weeks. Another thing is, if it is a major procedure involving a general anesthesia, I would probably like to be very sure that there is no infection there. Another thing, any thoracic surgery or a cardiac surgery, I'm a little concerned prior to undergoing the procedure. So I would probably suggest to continue for any major surgeries plus general anesthesia. And as far as the risk for healthcare worker transmission is there, probably what was in 2020 is probably, we are in a different position right now because we didn't have any vaccines at that point of time. So all of us are expected to be vaccinated. Perhaps there is a small add-on reason with respect to the risk of healthcare worker exposure, but more so for the patient perspective, I would not like to have a patient infected with the virus undergo a major surgical procedure unless it's an emergency or a semi-elective procedure. Any elective procedure, this is my personal view, I'm not sure what the other panelists think. So I would probably continue to screen anyone prior to any major surgical procedure, especially involving the general anesthesia.
And the next question which follows is, how long would you wait before you clear the patient for surgery? Would you wait 5 days, 10 days, 2 weeks, 3 weeks? What is your recommendation?
It depends upon what is the impact of virus on the patient. If the patient does not have symptoms, it's just an asymptomatic carriage, probably 5 to 7 days is good enough. But anyone with a mild disease or a moderate disease involving the lung, or someone with a severe disease involving the lung, probably I would probably leave it to ad hoc on the situation, how the patient recovers from the infection. And then, of course, the nature of surgery and the nature of anesthesia involved, all these things will be figured in. Asymptomatic patient with no clinical or radiologic. When I say radiologic, it's not CT scan. At least a chest X-ray is good enough in most of the situations. I know that we are used to have CT scans in the diagnosis of COVID, but I think we all diagnose chest X-rays. We all use chest X-rays for the diagnosis of pneumonia. And a normal chest X-ray in an asymptomatic person with no fever and respiratory complaints, I would probably wait for 7 days from the date of testing and would clear the patient. I'm not sure if there is any guidelines or a worldwide body recommending it, but this is what I would do in my practice.
I have lost Dr. Nambi. Is it my connection or?
No, he's online. I can see him.
Yeah. Probably if you have lost connection, can you hear me now? I've probably repeated in a single line again. Can you hear me again?
Just repeat it. Yeah.
Probably any asymptomatic person with no clinical or radiologic involvement. When I say radiologic involvement, for me, chest X-ray is practical enough. I would probably wait for 7 days before I would clear the patient for surgery. And anyone with real disease out of the infection, depending upon the clinical scenario and the urgency of the surgery, I would advise to take upon an ad hoc decision on that individual patient.
Thanks, Dr. Nambi. I'm going to ask a few questions for Dr. Gagandeep. The first question is, what is your definition of fully vaccinated?
My definition of fully vaccinated in the current scenario is 3 doses above 60, 2 doses below 60.
Okay, that's very precise. Right. The other question which has come up very often is, now during the times of Omicron right now, inevitably when they are ready to go for a booster, they come down with Omicron. So how long would you suggest they wait before they go for a booster?
So CDC recommendation is go as soon as you've recovered. WHO says, other agencies say wait anywhere from 1 to 3 months. I think if you want the antigenic benefit of vaccination, you should wait a minimum of 4 weeks.
Okay. And the ideal time, do you agree with the government's recommendation of waiting 9 months before you go for a booster after the second dose?
So I have my doubts about whether we've actually defined what complete primary immunization is at the moment. We were in a hurry to get vaccines made. We did phase 1, 2, and 3 studies. But usually you do phase 2 studies where you look at dosing intervals, you look at antigen concentration, you look at number of doses. And I don't think we did enough of those studies telling us what gave us the best possible immune response at an early stage. I think if we were to go back and revisit that situation now, we might very well land up exactly at where I have said what we should consider full immunization, which is 2 doses when you're younger and 3 doses when you're older, and possibly with different intervals than the ones that were defined in the pivotal trials that were done.
Right. Thank you. Over to Dr. Tanu now. Tanu, sorry, give me a minute. What should be the quarantine period? We are hearing varied news. The USA says 5 days is enough. The UK says 10 days, but if you do a lateral flow assay on the 6th and the 7th day and it is negative, go ahead and remove. France and Japan says wait for 10 days. New Zealand says 10 days in the vaccinated and 14 days in the unvaccinated. And WHO says 14 days. So there's a huge confusion. And Indian government says 7 days after testing. So what do you think is reasonably correct? I think you're muted, Tanu.
No, we can't hear you very well.
Okay, I will join through my mobile.
Okay, I think Tanu is going to join through mobile. So we'll give her a few seconds and see if she can join. I think I'll give her another 10 seconds. If she's not joining, we'll go to the next panelist.
Can you hear me?
Yes, we can hear you, Tanu. Go on.
Sorry for that. So, like I said, that early on also, maybe about more than a year back, we had data that people who had infection with COVID-19 did not have cultivable virus after 5 to 7 days of onset of symptoms. And therefore, the CDC had come out with a recommendation earlier also that 10 days for mild disease and 20 days for severe disease is enough. This is excluding the immunocompromised, where you can have replication going on for some time. But despite this, they didn't make changes to the isolation period because, they were somehow able to manage with these days of isolation. But now with Omicron, what has happened is that there is so much infection in healthcare workers and people, and there's so many man days that are being lost that the period of isolation has gradually declined. And in my opinion, 5 to 7 days is probably enough to isolate, provided that the person has no fever. And this is, I think, akin to what we used to do for influenza, that, once the person does not have fever for 24 hours, they are non-infectious. So I agree with this 5 to 7 days period of isolation after onset of symptoms, provided the fever has resolved.
Right. The other question which is often asked is, I live in a family, my wife is tested positive. Can I go to work? Both of us have been fully vaccinated.
Yes. So the problem with the current wave Omicron is that there is a lot of infection even in vaccinated people. So if there is a close household contact and you have not been able to wear masks, then the chances are quite high that the other person, despite being vaccinated, would get infected. So it is better that these people do not go to work at least for the next 2 to 3 days, because many of them inevitably get symptoms. And then if they do not get symptoms and they do have to join work, then after day 5, they can get tested. Here also, the CDC has a different set of recommendations, because as per them, even if you have had a close contact with, Omicron or COVID-19, and if you are fully vaccinated, you can actually go to work using a mask when you're around people. And so I think it is also a matter of, how important it is for those people to go to work, or can they work from home. For example, in our hospital earlier, we were saying that healthcare workers who have a person at home who's infected should stay isolated and test and then come back to work. But we have such a serious shortage of healthcare workers that now we have excluded them. They can come to work unless they get symptoms. So I think it also depends on how important it is for them to go out to work.
And it's going to be difficult for whom to decide that this is their work is important or not. Anyway, I think there's still confusion. Over to you, Gopal. Now, one of the interesting issues in India is that Monoprover has come in. About 5 or 10 companies have come in with Monoprover, and there's a huge push to use Monoprover. And you very, categorically said that the role of Monoprover is at best, probably waiting for a disease or, something like that. So the question people ask me is, okay, we know it may not work well, but what is the harm in using it? It costs about 1,000 or 2,000 rupees. So come on, use it. The patient is happy. The companies are happy. So is there a downside to using Monoprover in India?
Well, the one clear downside is this unclear teratogenicity, mutagenicity, genotoxic. So I think in women, certainly women of childbearing potential, it should not be used. If you ask me whether I would give Monoprover to a male, high-risk person, unvaccinated, I don't have a problem with it. It's been studied. It's been shown to work. But if you're vaccinated, why would I not give you the best available therapy? Why would I not give you a drug that drops your risk for clinical endpoints by 87%, which I have used many times and I have good clinical experience with, in other words, Remdesivir, rather than give you a new drug which drops your risk by only 30%. And you're really treating yourself. You're not doing the patient any favors by giving them an inferior therapy. And this is exactly what the guidelines say in the US. You give them either nirmatrelvir or sotrovimab or Remdesivir. Only if they can't, or if they can't get it or some contraindication, do you even go to Monoprover. Everybody recognizes it's an inferior drug. There is no reason to use an inferior drug when we have a superior drug available.
But Gopal, I'm going to push you a little harder now. You know that Remdesivir has gone through a huge, curve up and down. It started off saying that you have to use it for all patients. People were running around and, paying thousands of rupees to get Remdesivir. And then they said, WHO said, no role for Remdesivir. And Trump said, yeah, use it. And then they they said, okay, hypoxic patients between 7th and 10th day. And now one paper has come out saying that use it between 3 and 7 days and it gives benefit. So, you may get another paper tomorrow saying that it is rubbish. So what would you do? Aren't we vacillating too much with remdesivir?
No, I don't think so. I think it is because of the way this drug was studied. When COVID came out, it was a nasty disease. They used this drug in very seriously ill patients on ECMO, on the ventilator, at which point all viral replication has ceased. It's all inflammation and sequelae at that stage. There is no active virus beyond day 5, day 7. We were just having this discussion earlier. So if you truly want to give an antiviral, you give it yesterday before the patient gets symptoms. You can't do that. So you at least try to give it in the first 3 days when there is culturable virus. So this is the first study which uses the drug at that early endpoint. And unfortunately, it's a parenteral drug. Unfortunately, I wish it were an oral drug. So this is the first time remdesivir has been properly studied. There's no point using it after day 5, day 7. Even the studies on remdesivir clearly show if you use it at that stage, it doesn't work. So this is where it should be used. I rarely use remdesivir in a hypoxemic patient, just like the WHO says, but I often use it in the high-risk, unvaccinated, very early presenter.
Vaccinated? Does it make a difference, or?
We don't know the answer to that. I told you, if you just shift that curve, the placebo curve, the recovery is a little bit higher because we know Omicron behaves less virulently, maybe no benefit at all. But if I don't know what strain it is, and it's a high-risk person, say severely immune compromised, multiple comorbidities, fair enough. Sometimes I give the benefit of doubt.
Thanks, Gopal. Coming back to you, Nambi. This is very often asked. So, even though a lot of people know the answer, I'm going to ask this question because I get this asked every day by at least 10 people. If the patient is quarantined for 7 days, should he go for a repeat RT-PCR or a repeat antigen test for whatever reason, to remove isolation, to get back to work, to decide on anything? Is there a necessity?
Personally, I don't see a need for repeat RT-PCR in any kind of situation. Antigen test, perhaps in a patient who is already positive, again, I don't see a need unless you want to see the period of infectivity, something like that. I think it's all theoretical. In a practical language, I would say do a test once, make a diagnosis. Patient is asymptomatic for 3 days in terms of fever not being there. I think that is good enough to remove isolation. That was the thing that we were doing for all respiratory viruses so far. And COVID, I know that it was put on the pedestal when it came in 2020 because we didn't know what kind of disease it was. Now we know how to protect ourselves. Let it be the PPEs or let it be the vaccines. So when we need to keep things simple. So any respiratory viral infection, we are looking at 5 to 7 days from the date of onset of symptoms. I think that is good enough. So we cannot keep on thinking about this minor period of transmission after 7 days. Someone would say till day 10, day 9, it would be there. But we are all expected to be masked. We are all expected to be vaccinated. So I think whatever the risk is there after day 7, even if someone says 10%, 15%, I think it would be negated if I am vaccinated, if I am using mask at all situations. So I don't see a need for repeat PCRs. So symptom-free for 3 days, by day 5 to day 7, I think people should be off isolation.
Right. I mean, I'm happy you said this because one of the questions, again, a lot of healthcare workers ask, and one person has asked, is it acceptable to expose healthcare personnel in the operating table by not knowing the current infection status of the patient who's being operated? Isn't that putting the healthcare worker at a higher risk?
I think risk is there everywhere, everything that we do. So we are expected to be masked. We are expected to be vaccinated. So probably in 2020, I may have had a different answer. In 2022, I don't see it as a problem anymore. So I think as long as you wear mask, as long as you have taken the vaccine and whatever the precaution dose, a booster dose that is going to be available, and if you're going to take that and it's going to give you that 3 months of probably workability for all health workers, because I don't think this precaution dose or booster dose is going to give us 10 years of immunity. It's going to be for the next 3-4 months. That's it. So I think as long as we take that, use mask, I think that's good enough for the next, until we cross over this third wave right now.
And again, on the same lines, what is the current role of personal protective equipment? We started off wearing the space suits with the, respirators and all that. And we have now moved to a situation where I think a lot of people, including me, sometimes are callous about even the wear of masks and using protective equipment inside the wards. So what would your recommendation be for a practicing physician?
I think at the best, it's a droplet infection. So at the best, it's a droplet infection. It can be airborne in certain select situations. let it be intubation, ventilation, bronchoscopy, or at times when you take samples for PCRs, when you're going to put in a probe into the nasopharynx or throat. Apart from all these situations, a good surgical mask plus hand hygiene at appropriate situations. The WHO 5 moments of hand hygiene is good enough. N95 mask is an add-on, especially if you're working in an ICU where close prolonged contact with the patient is expected. So I think I would probably keep it very simple: mask plus hand hygiene. So whether you use a surgical mask or N95, probably I will leave it to that individual. But I think as long as mask and hand hygiene is there, I don't see a real role for all these spacesuits. I know that you believe, you know my sentiments, and probably it was the initial 2 months I was using all those things. And after that, all I have used is only a mask and a hand rub. That's it.
That's very provocative, Dr. Nambi, but we will move on. I'm going back to Dr. Gagandeep. What is the role of vaccination, the immunocompromised, especially cancer patients, since they tend to clear virus less effectively? Shouldn't they be isolated longer? And what kind of vaccinations would you advise for this group of patients?
So this is a group of patients where I would think seriously about considering the use of better immune profiling. Ideally done as studies, but even considering it for the use of individual patients, it's very clear that they need additional doses of vaccine. The question is which vaccine and at what time point. And unfortunately for us, the vaccines which have been demonstrated to work quite well in immunocompromised patients have not been available to us to evaluate so far. So with Corbevax, Covovax coming in, hopefully with having other platforms available in India in the future, I hope we will be able to generate data that will allow us to have better sort of vaccination schedules for people who are immunocompromised, as well as better monitoring protocols for immunocompromised patients. We don't have them at the moment.
Right. And another burning question, which is again asked again and again, is the choice of the booster dose. Would you give Covishield in a patient who has had Covaxin, or would you continue to give Covaxin? What does science say? What is practicality? What is your thought?
So if we look at the recommendation that the government has made, it's that recommendation has been made because the limited amount of data that we have doesn't tell us anything about vaccine effectiveness. There are data that say that, you give another antigen, third dose of any antigen, your antibodies will go up. That's not exactly, new to science. We know that if you give an additional dose of any vaccine 6 months after you've given the previous doses, you will see an increase in antibodies. That's what we've seen. But is it the best combination to have? Well, at least based on immunogenicity data from other parts of the world, we'd be better off with heterologous dosing. But again, that requires data not available in India.
Thank you. Now, Tanu, you're a pediatrician and you hold chickenpox parties to expose kids and, other such gory stuff. So if the Omicron situation is not bad, why don't we let it spread and, let's have Omicron parties and, why should we worry so much about it? What do you say?
Yes, so there is a lot of talk going around that, Omicron is like a natural vaccine. It's a nasal vaccine and it's there to immunize people. But that is not true because it does cause disease. And it's causing maybe the vaccinated and the ones without comorbidities are okay, but there will be immunocompromised people and unvaccinated who will have a problem. Besides, we also know that, whenever you have unchecked replication of the virus, you also have the increased mutagenicity. So you have an increased tendency for giving rise to new variants. So I think it is in everybody's benefit that, we should kind of flatten the curve even with Omicron as much as possible. And third, we don't have any data to say that, when we have chickenpox parties or rubella parties, we know that the person will be protected against chickenpox and rubella for life. But we don't know whether that's true with Omicron, because you may have Omicron and you don't know, you may have infection with Omicron again, because where do we know that it doesn't protect against reinfection against the same, or whether some other variant. So because of all this, I don't think it's a good idea to get deliberately infected with Omicron. And we don't know what is the impact on long COVID. That data has still not come in. What are the other consequences? So basically, I think at this point, it doesn't make sense for all the reasons that I've mentioned, for us to deliberately go and expose ourselves.
What is your recommendation on duration of quarantine for international travelers to India who have a negative test on arrival?
So I really don't see any logic in this quarantine. That would have been important early on. And now it is raging in our country, and I'm sure the numbers which are being depicted are a fraction of actual number of cases. Because in Mumbai, almost every 1 in 4 person is infected. So obviously, I don't think, if we already have widespread community transmission of Omicron, then what is the point in, quarantining these people if they have a negative PCR test, or even doing a PCR test at the time of arrival, because it's already widespread. So I don't see any point in doing either testing these people or in quarantining them.
Thank you, Tanu. Gopal, you are pushing for Remdesivir. So one of the questions asked is, how soon do you think we need to give Remdesivir if it's going to make a difference? Would you start it on day 1 in high-risk patients? Would you wait till 3rd day? Because a lot of people get better by 3 days. So what do you suggest?
And just to clarify, I have no stock in any Remdesivir companies, or I don't do anything for them. If you are going to give an antiviral, it makes sense to give it the day you first see the patient. Because you have the vaccine history, you have the comorbidities in front of you. The study exclusion criteria was more than 7 days, but really most patients got it early, within the first 5 days. So I would start it the day I see the patient. Once I know that this is a patient who's a potential candidate, I would start it without hesitation in an unvaccinated host, vaccinated on a case-to-case basis, because there is no data.
Okay. And what about early Remdesivir? Would you recommend it for all cancer survivors, transplant patients, diabetics, etc.? Can we be more, when you write the guidelines, can we specify these groups as specific groups where it is warranted?
Definitely for unvaccinated, no question about it. For vaccinated, the scientific answer is no data. Again, on a case-by-case basis, for instance, if somebody were a candidate for monoclonal antibodies, they had a non-Omicron strain, I would probably use that first. If they had an Omicron strain, on a case-by-case basis, if you had 6 comorbidities, cancer survivor, known vaccine non-responder, yes, but maybe not for the 60-year-old with slightly high blood sugar, probably no. So it's really a clinical judgment. Can't give you an evidence-based answer to that.
Right. Last question for you, Gopal. There's a lot of, any reason why there is persisting dry cough for this variant? And on same lines, a lot of people complain of severe throat pain. In fact, that is a reason why a lot of people insist on antibiotics, because they think that when there is throat pain and there is a respiratory infection, antibiotics will make a difference. So what would you do for the cough, and what would you do for the throat pain?
The cough is not due to a pneumonia. Typically, it is due to a bronchitis, as we see for all respiratory viruses. Post-viral cough can go on for up to 4 weeks. So I would make sure they're not wheezing, first of all. Auscultate them, make sure there is no wheezing, which would require a bronchodilator. If they are not wheezing, then I would just give them a cough suppressant with dextromethorphan. A lot of these commercial things have a lot of systemic phenylephrine, etc., which may be bad for people with the cardiovascular diseases. So I would avoid those combination therapies. They have a lot of sedating antihistamines, which don't work for viral respiratory infections, just dextromethorphan alone. And for the sore throat, it's all symptomatic treatment. You know the old saying, a lot of medicines, 7 days, no medicines, 1 week. I think Dr. Nambi said that first. So whatever you want, salt water, gargles, whatever, they'll get better.
Thank you. Dr. Nambi now. What are the guidelines for wearing double mask, like a surgical triple layer mask over an N95 mask or vice versa? Are there any guidelines? Do you recommend anything like that?
I would probably say use one mask properly. That's it. I would just put it at that level rather than looking into use of two masks, all those things. And the problem here is we are not trained to use masks properly. Most of us kind of pull down when we talk to patients, and we've had this in our patient experiences. So they would know that they have COVID, but they would come close to us, pull the mask down, and then talk to us to give the history. And there was one patient who said that he couldn't hear me properly, and then he was pulling his mask down as if his mask is covering his ears. So I think as long as we use one mask properly, and probably I'm not for reuse of any kind of mask. Okay, so if it is used for a day and if you use for 6 to 8 hours, I think it should be disposed. Fortunately, India is doing better in that count with respect to US, which has all the resources in the world, but they don't have enough funds to give masks to their healthcare workers. So at least we have the access to masks. I think one mask used properly during the day, I personally feel is good enough. I don't think we should use this double mask, although that's what I feel. I'm not sure what Anu or Dr. Ram Gopal thinks regarding it.
Okay. Do you believe in prophylactic admissions, especially private hospitals like us? There are a lot of people, high-profile patients who say, no, I don't want to take a chance for two reasons. One, I am 65, I'm a diabetic, I'd rather come into the hospital. Or two, even though I have a separate room to stay, in the next room my parents stay, in the opposite room my child who's an asthmatic stays, I don't want to stay at home. So how do you handle these?
I think probably in 2020, I would have said kind of partial yes to it. But in 2022, I would not do that. I would not do that. And I think these kind of patients early in the phase of infection, they're going to shed the virus a lot to the healthcare workers. Anyway, they're going to get some blood samples drawn, the phlebotomists get exposed, they're going to get some x-rays done. And if it is a cardiac patient, an echocardiogram done. So there is unnecessary exposure to the healthcare workers. And it's not going to stop with them. They're going to carry it to their family members. So I don't think we should be doing it. And in the best, I think all of us know that Omicron behaves as a viral upper respiratory infection in the majority. In fact, the role of antivirals in the treatment of Omicron, I'm not still very clear. And personally, I've not used any antivirals in dealing with the viral URTI that we have, this pandemic of viral URTIs now. So if you're not going to admit a patient for treatment, I don't think we should be admitting for all other reasons, unless it's going to be an elderly couple and there is no one taking care of them at home. So they're staying alone, and you know that their saturation is fine, their respiratory is fine, but they cannot take care of themselves properly. They have some giddiness, there is no one to feed them food. So for social reasons, probably yes, but definitely not in a fit adult who can take care of himself. I don't think we should be encouraging these kind of admissions, because it kind of puts the healthcare workers on a perennial, persistent exposure. And it's not going to stop with them. They're going to transfer to their family members, and then there's going to be a perpetual cycle. So I would probably say no to it.
Okay, thanks, Dr. Nambi. Dr. Gagandi, now, do you believe in the fourth dose?
You know, we've encountered this virus about 2 years ago. Or if Omicron is showing us something, it's showing us we're going to see this again and again. I firmly believe that vaccines support the immune system, but the immune system is very capable of handling most infections, particularly viral infections, on its own. So I don't think that it's likely that we should go beyond 3 doses of vaccine in some groups in the first set of vaccinations we do. Will we need a booster maybe every 5 years or thereabouts? Perhaps. We'll find out 5 years from now. Certainly don't think that a 4th dose is needed for pretty much anybody at this stage. If you didn't respond to 3, I'm not sure how much a 4th will help.
So you don't subscribe to the notion that annual vaccinations may be necessary like the COVID, like the influenza?
I don't think so. I actually think that vaccines do very well against SARS-CoV-2, much better than vaccines currently available do against influenza. I think we need to trust our immune systems, give it time, and learn how to handle the combination of infections that we are likely to see, along with the support of at least initial protection that comes from vaccination.
And your opinion on vaccination in pregnant women and in children?
I think pregnant women absolutely should be offered vaccination. And for children, I think it's inevitable that we will get to vaccinating children when vaccines become available. Do we really need to vaccinate children? That's a different matter where cost benefit really does not show benefit of vaccinating children. But that's at a population level, and at an individual level, it becomes much harder to explain. Because there is, at the individual level, the potential for a small amount of benefit.
Right. And lastly, inside information on what do you think is the best vaccine? If I had the choice of all the vaccines which are available for a primary course and for a booster, what would you recommend?
I would probably take a mixed schedule. And I would most likely, I think ultimately if we get live attenuated vaccines, those might wind up being the best. We don't have them at the moment. And if we could look at targeting both systemic and mucosal immunity, then that would be something that would give us more likely, more comprehensive protection. But at the moment, we really don't know. All of the vaccines are performing pretty well. And it does seem like if you've had a combination, if you've had 3 doses of vaccine, or if you have a combination of infection and vaccination, your immune response begins to broaden quite nicely. And that's what we are looking for, broad protection against a range of variants. The question is now, how do you make this even better so that the duration of protection is also extended?
Right. And you don't think that in future there will be customized vaccines for a different strain which may come? You don't think it is necessary?
I think we might wind up with maybe one upgrade. We are making 2nd generation, 3rd generation vaccines already, but whether those will wind up being the solutions or the platforms where we constantly reinvent vaccines, I don't think that is likely to happen. But will we use better vaccines in the future? Yes.
Thank you very much. Dr. Tanu, one question is, recent studies have shown that cloth masks may not be protective since Omicron particles are too tiny and pierce the cloth masks. Most of the public use this and are insisting on pseudo protection. So what is your recommendation for public with regard to usage of masks?
So I would say that, for the public, which are highly immunocompromised, like elderly people, cancer patients, if they are going out, then maybe they should use either 3-ply surgical masks or N95 mask. But other than that, the usual public should continue to use cloth masks because, we really don't have data about how much this protection will be enhanced and whether it is actually possible, and will it not create a shortage of these masks for the healthcare workers who actually need them. So I think we should stay with the WHO guidance on masks, which say that only the highly immunocompromised and those people may use the surgical or the N95 masks, and others should use the 3-layer cloth mask. And I think it's not so much as the mask, but the way the mask is worn, because most people would not wear even an N95 mask properly. They would keep taking it off, putting it on, and those things are there. And now we also have some kind of cloth masks, which also have virucidal and bactericidal ability, which don't need to be washed daily, which have been approved by FDA, like from Living Guard, etc. So people could even look at those kind of masks instead of the normal masks.
Right. And do you think that the second dose of the vaccination can be given in the early trimester of pregnancy, or should it be deferred to the second or the third trimester? What is your thought?
No, it can be given because we should protect the pregnant woman as soon as possible. So as per, if it is Covaxin, then 28 days apart, and if it's Covishield, 3 months apart. We should not delay it because there is no data to suggest that these vaccines are teratogenic. So they should be protected as soon as possible.
Right. Thank you. And lastly, over to you, Gopal. A lot of people, even with Omicron, continue sometimes having a low-grade fever, 99.4 to less than 100 beyond 7 to 8 days in some situations. Do you think it is cause for concern, or would you say, they just keep quiet?
These patients, you always have to look for the common sequelae following any respiratory virus. You look for sinusitis, you look for a bacterial pneumonia, which is uncommon with COVID, but certainly day 7, day 8, that's what I would look for. If they're immobilized, look for a DVT, look for COVID manifestations elsewhere in the body. But just for fever alone, I would not step up therapies. I would intensify paracetamol. I would even give NSAIDs with caution, with monitoring of renal function. There are studies showing that NSAIDs are safe in COVID. So I would not, get very aggressive with these patients. Work them up, get an X-ray, get blood tests, etc., but don't jump into unnecessary therapies.
Right. And the study you said about sotrovimab, which is effective for Omicron, said it was used under 5 days, but I think it is licensed to be used under 10 days. Am I correct, or is there?
I will check the package insert. I have never used the drug, just like you, but it's
Right.
a drug to be used early in COVID. Like any monoclonal antibody, you're best off using it before antibodies form. So first 3 days, max 5 days.
Okay. And the newer monoclonal antibodies, do you think there will be role for them with more and more boosters being given now? Do you think there is any role? Do you think that we should still invest in that, or do you think it is just pharmaceutical?
There are two aspects to that. One is whether they are active against Omicron and other future variants. So clearly, imdevimab, cassidymap won't be very useful in the future if Omicron takes over. And the second aspect is there will always be patients who don't respond to vaccine. The entire hemato-oncology group, the entire bunch who gets rituximab, there's no point even expecting a vaccine response. So the long-acting one, which I described, the one with the unpronounceable name, that one is particularly useful for immune-compromised hosts. You give them a shot, say they're undergoing a transplant, you know that they won't have an antibody response for a while. So in that situation, selected patients, they will be useful.
And lastly, the chances of post-COVID fungal infections following Omicron. The black fungus created a lot of panic. Is there any concern about such infections after Omicron?
Well, if Omicron progresses to severe disease, ending up in the ICU, if you get a lot of inappropriate steroids, if you don't control your sugar well, then yes, you will see a lot of fungus. Hopefully, we have learned those lessons from the previous wave. Control the sugar well, don't use excessive doses or unnecessary doses of steroids.
Okay, I think there's still a lot of questions coming. I think one last question for Nambi before we close up. Dr. Sendur, sir, many patients are asking for CT scan after 2 weeks or 1 month when they come for post-COVID care. What is your advice?
I don't think we should be doing it unless they had a severe pneumonia upfront requiring ICU care. And in that situation, if you want to look into the extent of lung damage and recovery, otherwise asymptomatic infection, I don't see a role. Mild infection, no role. Moderate, no role. But anyone in the ICU requiring oxygen for more than 4 or 5 days, and when they come with still some kind of oxygen support, probably from the lung standpoint to know the extent of lung recovery, any fibrosis, or if you suspect any other secondary infections like fungi, bacteria, for whatever be the reasons. Otherwise, I don't see a role for routine CT scans.
Thank you very much. I think it was a wonderful session. I learned a lot from this session, and I hope you did too. I'm going to hand over to Dr. Priscilla for her closing remarks. Thank you very much, all of you.
Thank you everyone for joining us. It's been a wonderful session, and I know there are a lot of questions that are left unanswered. I think we were trying to answer some of those, but keep in touch with CIDS. We promise to have CIDS webinars on a regular basis. So we hope that all of you stay safe, and bye everyone.